Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Alexander Saw. Dr. Saw is a native of Fremont and was born at Washington Hospital. Dr. Saw completed his bachelor's degree at Haverford College in Pennsylvania. He completed his internship at Massachusetts General Hospital and his residency at Harvard Combined Orthopedic Residency in Boston. Dr. Saw completed his fellowship in minimally invasive and revision hip and knee replacement at Rush University Medical Center in Chicago.
Thank you all for coming here today. I hope to provide you some information about knee pain, knee arthritis, and various treatments, some of the new advancing technologies that we're using for knee replacement. There's going to be plenty of time for questions. I'm going to try to cover a fair amount of material, but you can certainly, at the end of each section, I'll give you an opportunity to ask questions, and at the end, for certainty, we will answer whatever questions you have. But it's a great privilege to be here, and again, I appreciate you taking the time to be here to learn a little bit about knee replacement, knee pain, and various treatment options. The reason I enjoy giving these kind of community talks is because this is my hometown. Again, I was born here. I was born in that hospital. My father was a head and neck surgeon for 30 plus years, and it's just wonderful to come back and treat the same patients that my father treated or work with some of his colleagues. So he's always stressed education. I'm trying to practice medicine the same way he did 30 years ago. So I'd like to try to give back with educational talks like this. I spent my training out east, as already mentioned, was on the East Coast, Midwest, and came back here in 2008. And again, this is my dad. I don't know, some of you may even have known him or been a patient of his, but again, he was a head and neck surgeon for over 30 years, and he still continues to volunteer at this hospital even after retirement. I think he's one of the only surgeons who actually volunteers at the hospital where he retired from. So Ben Saw is my father, and that's the footsteps I'm trying to follow in, and that's why I love being here. And as much as I love the practice of medicine and being in the operating room treating patients, it's about serving the community. And so these kind of recognitions that I've received from the community, that means everything to me. Again, that's why I do this. So it's a great privilege to be here and be able to talk to you about my specialty. Some other things about me is our group, Dr. Dearborn and I, we are very involved with both the hospital. We're both trustees of the hospital, which is how the hospital gives back to the community again. We're directors of our Institute for Joint Restoration and Research together. We also chair our research projects, chair the orthopedic department right now, and also because of the volume, because of the amount of research and quantity of surgery we do here, it allows us the opportunity to work more on a national level. So these AAOS, this is the American Academy of Orthopedic Surgeons. It's the largest national orthopedic association, and we are very prominent in that because of what we're able to do here. So I want to share with you what we are sharing with the rest of the country. So this is the overview of what we're going to try to talk about today. We're going to try to cover a bunch of topics. It's in the outline in front of you. We'll talk about some knee basics very quickly about knee anatomy, function, and arthritis, so you have a foundation to understand what we're talking about. We'll then talk about non-operative treatments, medications, and other things to exhaust prior to surgery. We'll then talk about surgery, both standard treatments and the less invasive surgical techniques. We'll then talk about some of the controversies you may hear on the radio or see on television or read in magazines, and I'll give you an opportunity to ask any questions you may have about these new and developing technologies. And then I want to share with you some of my experiences with some of these perioperative advances. Every year there are things that are coming into the marketplace to try to improve already good outcomes. Obviously it's a balance of using something new that will be better without adding new complication or risk, but there have been some interesting developments which while small on their own, when added together, can make big differences. So I'd like to share that with you. And lastly, talk a little bit about our Institute for Joint Restoration and Research and really the keys to success that we found in our experience here. So first, for knee basics, just want to look at the anatomy of the knee. In these diagrams here, you can see this is the femur bone on top and the tibia shin bone on bottom. And the white cartilage on the ends of the bone basically are what allow the joint to move freely and without pain. Okay? The ligaments are on the side of the knee. So here are the collateral ligaments, and there are ligaments on the inside of the knee. But these two ligaments here, you can see, is the anterior cruciate ligament, or the ACL. You hear about that every day, right? If you read the sports paper, athletes are injuring it all the time. The reason it's called the cruciate ligament is because it crosses with the other one. So this is the anterior cruciate ligament, this is the posterior cruciate ligament. So those two ligaments cross in the middle of the knee and are major stabilizers of the knee. So you all knew about it, you just didn't recognize it on the diagram. But what we typically see in my office are people who are eroding cartilage, or the white on the end of the bone. Again, that's what's important to allow painless and free motion of a joint. So in this animation, you can see the knee from the side. You can see when it bends, right, you have to have cartilage along that entire surface so that there's no pain and that joint can move freely. This is the patella, or the kneecap in the front of the knee, and that glides on the femur, you can see, as it bends. So when you go upstairs or get out of a chair, you need to have good cartilage to do those motions comfortably. All right? It's important to know that this joint feels 3 to 5 times body weight, maybe 7 times with jogging. So when people have increased weight, losing weight, it's a multiplier of that and how much force is relieved from the painful joint. Something to remember, and we'll address later. But the main reason we see patients in our office is because they've lost that arthritis. They've lost that cartilage, and that's what we term arthritis. When that protective white layer is eroded, the bone underneath is exposed. So imagine that white end of a chicken bone. If you took a knife and scraped that away to get to the raw bone, every time you walk on that, do other things, you can imagine that can be painful. So this is another example where this is pristine cartilage. It's smooth, it's white, and that's what the joint looks like. But this is a pitted, there are basically potholes in that cartilage. There's exposed bone. That's the pain. That's what causes pain, swelling, stiffness. It can cause locking or catching, or cause people to need a walker or a cane, because that joint is painful. The question is why do joints wear? Well, you can make the analogy that the joint is like a tire on a car. And why do some tires wear faster? Well, that tire may wear because it's a bad tire. Maybe there was a defect, so it was set up to wear sooner. Or maybe it has to do with the driving habits of the person owning that car, or whether they're on the high use right lane of a freeway or the low use left lane. It has to do with how that joint or car is being used. You can imagine if the wheel or leg is out of alignment, that can affect how long it can last, or the size of the car, of course. But the bottom line is that with whatever the reason, arthritis is the breakdown of that cartilage. It's important to know that there are some people who believe or they have knee pain, but the source isn't actually from the knee. Hip arthritis, and this is an example of hip arthritis on x-ray, where the ball and the socket are now eroded. There's no protective cartilage there anymore. 1/3 of hip patients actually will present with pain in their knee. So I actually had a patient a couple years ago who was being treated for knee pain with medications, injections, physical therapy, and had a surgical date with another surgeon for knee surgery. Actually, his entire problem was due to the hip. So we replaced his hip and all his knee pain went away. So just so you know, the two can overlap. Hip pain can present as knee pain. Usually not the other way around, but just so you know, hip arthritis can refer as knee pain. Now, what does arthritis look like? This is an example of arthroscopic photos. Arthroscopy is when you go into the knee with a little camera, pencil-sized shaped device. Some of you may have had knee arthroscopy in the past or know someone who's had it, but it gives you a bird's eye view of the knee. You can go in and actually see it with high definition cameras and take pictures. This is a close-up view of the end of the thigh bone, the femur, the shin bone here, which is more flat, and here's that meniscus. That's healthy cartilage living in between the two bones. This is a very healthy knee. You can see how smooth it is. These are examples of knees that are worn. You can see there's a big pothole here where that white layer is gone. You can see how cartilage is missing, how it's flaking off, how it's eroding. Those are all painful knees. That's what it looks like on a camera with arthroscopy. This is what it looks like in the operating room. The skin looks a little yellow because there's a protective yellow antibiotic barrier on it. But the bottom line is you can see this knee, the end of the thigh bone here, you can see there's big pothole, no cartilage left. Or on this one, it's all eroded away. See how that looks shiny like a cue ball? It's because that protective cartilage layer, just like on the end of a chicken bone, has been rubbed away. And that hurts with every step that that person takes. So that's why we treat that with surgery if needed. This is what arthritis looks like on x-ray. That white protective layer of cartilage is invisible on x-ray. And so when you have cartilage on the end of the thigh bone and you have cartilage on the end of the shin bone, when you put it together, you get a space like this side. That's what it looks like. The cartilage is invisible, but you know it's there because the bones are apart. On the other side, you can see how close those bones are together. Well, the only way that can happen is if that protective layer is being worn down. Okay? So we know that that person has arthritis. This x-ray is similar. You can see it's nearly bone on bone here. If someone tears their anterior cruciate ligament and then they have it reconstructed, this is what it will look like on x-ray. See how there's a tunnel here and a tunnel here? That tunnel is where the reconstructive graft is going to make up for the torn ligament. And this screw and staple are helping secure that graft in place. So any of you who have known someone who's had an ACL reconstruction, they'll have an x-ray that looks similar to this. This is the graft in place. And so just by looking at that x-ray before I even see the patient, I know that they had some sort of trauma, possibly a sporting event where they ruptured their ACL and had it repaired, and now they have arthritis. So just from that one x-ray, we can get a lot of the picture. And then this is an example of a more severe case where you can see not only is it bone on bone, but that leg is now severely out of alignment. This person has a problem walking, their knees banged together because it's so eroded. So it can vary from more mild to more severe. The bottom line with arthritis is unfortunately there's no cure. There's no way to grow normal cartilage. And I say that with a slight caveat. There is a way to take cartilage cells out of someone's knee or joint, and you can grow them in a lab. So you can theoretically grow cells. The problem is we don't have a way of putting them back where they need to be. We don't have a way of injecting them or inserting them in that area of defect. Because you can imagine if you have a malaligned limb, and every time that person walks, it's rubbing bone on bone, even if we inject the healthiest or best cartilage cells, every time they walk, they're going to rub them right away. So that's why the technology's not quite there yet. So unfortunately, it's like that blown tire. Once the tire is completely ruptured, we have no other treatment other than to replace it. When patients walk in my office, the things I look for is I look at how they're walking, look for rashes or swelling, their range of motion, stability. All these things give me an idea of what's happening in the knee. And what's most important for both patients and physicians alike to remember is that physical exam is the key to a timely and accurate diagnosis. It's based on exam. Unfortunately, nowadays, some people tend to depend too much on imaging studies. Imaging studies confirm a diagnosis, but they shouldn't be used to first make the diagnosis. And I'll get to the reason in a moment. For arthritis and most knee problems, the initial study would be an x-ray. It's very simple, inexpensive, and it lets us see for fractures, cartilage space, and other things. This is an example of a CT scan. The reason we don't get CT scans routinely is because a CT scan is many, many x-rays in a row put together to give you a more detailed evaluation of the bone. But that's a lot of radiation, and it's expensive. You don't need that to detect something like arthritis. Similarly, an MRI, which looks like this, the bottom right-hand corner, is very, very detailed. It's almost too detailed. It doesn't have radiation, but it is costly. We use this typically to look more for things like a meniscus tear or an injury to the soft tissue, because you can see all the soft tissue in this image, but we don't use this first line for knee arthritis or other things elsewhere or otherwise. The reason you don't want to jump to an MRI is because if I took an MRI of all of you in this room, some of you would have an abnormality which wasn't bothering you. It would be too sensitive. It would pick up too much. And so just because there is an abnormality doesn't mean it's causing symptoms or pain. So that's why sometimes we have to be a little more careful in what kind of test we order. Again, physical exam is really the key. Okay? In terms of non-operative treatments, this is one of the first things that you can try. Non-steroidal anti-inflammatory drugs. They're called NSAIDs. These are your Motrins, Advils, ibuprofens. What they are they're very mild pain relievers. They do provide some anti-inflammatory effects. So they're good for your routine ankle sprains or muscle strains, but they're also good for arthritis type pain. The downside of them is that they can cause some GI upset, that they are metabolized by the kidney. So people who have kidney problems, you have to have caution taking these. And the last thing is that they do have a small amount of blood thinning effect. So for people who are on blood thinners already, Coumadin, Xarelto, Plavix. You may have to be cautious, have to talk to your primary care doctor whether you can take these because it may contribute to your blood thinning. But in general, these are safe medications. I give them to my children. They're very helpful for aches and pains and inflammation. Aspirin is similar, another anti-inflammatory or NSAID. The only difference is it has an irreversible effect on platelets, meaning it thins your blood a little more and a little longer. But the reason people take it for cardiac reasons is because of its antiplatelet effect. Now, acetaminophen or Tylenol, it's important to know that it is not an anti-inflammatory. A lot of people get that confused. It's a very different medication from the prior NSAIDs we were discussing. It does reduce pain, it reduces fever, but it is not an anti-inflammatory. It's also not metabolized by the kidney, so if someone has kidney problems, they can certainly take Tylenol because it's metabolized by the liver. It also does not thin the blood. So people who are on blood thinners, people who have kidney problems, people who get GI upset, who can't take NSAIDs, this may be what they can take. But if you otherwise tolerate the NSAIDs, you could also take this. You could take them together. Okay. Analgesics, the Vicodins, Tylenol with codeines, other things like that, those are only pain relievers. They only mask pain. They don't treat inflammation. They don't do anything else. They just mask pain. And typically, if people need this, we usually recommend they have evaluation because you don't want to be on pain relievers for an extended period of time. Now, glucosamine chondroitin sulfate, how many of you in the room take this already? So a fair number. Glucosamine chondroitin sulfate is a building block of cartilage. It's a natural compound. It's a food. It's not approved by the FDA, meaning it's a dietary supplement. So there's no FDA regulation of what's in the product you buy. There's no studies to support it. So the idea behind this, if you take this pill, will it rebuild cartilage where you need it? Well, one of my mentors in Boston when I was training gave me a great analogy. He said, taking this supplement is like a bald man who eats hair. Right? Just because you eat it doesn't mean your body's going to digest it and put it just where you want it. Same idea with glucosamine chondroitin sulfate. Now, if the glucosamine helps you and you feel better, I have no problem with that. If at worst it may be an out-of-pocket expense, but just so you know, there's no data to suggest that it actually does anything. Our Orthopedic Academy actually recommends against it, not because it's harmful, but because it doesn't do anything. And it's a multi-billion-dollar industry. But again, if it works for you particularly, I'm okay with that. It won't cause any harm. In terms of other non-surgical treatments, things like modifying your activities, using a golf cart instead of walking, using the escalator instead of the stairs, and again, losing weight, all these things can help with knee pain or other joint pains. Therapy can help. Physical therapy can help with range of motion or strengthening. Organized program seems to work best, but what's important is this last line. The benefits are usually lost within 6 months of stopping that program. So if it is helpful, it's something that has to be continued, okay? If all those things fail, there are some things like injections. And the first and most common injection is a cortisone injection, which is a steroid. It's a powerful anti-inflammatory mixed with lidocaine and novocaine, which is it's a numbing medicine, like Novocaine at the dentist. So this helps temporarily with pain and discomfort. This does not reverse the arthritic process. This does not cure those areas of missing cartilage, but for a short period of time, someone may feel better. The other injection option is a hyaluronic acid, or viscosupplementation. You can see that these are more like gels. You can see they're very thick. It acts more like a lubricant. People mention the rooster comb injections. This is what they're referring to. There are many names, Synvisc, Orthovisc, Gel 1, whatnot. This has a mild anti-inflammatory effect. It has a mild analgesic effect, so it relieves some pain, but again, it's not curative. It's temporary. For some people, it lasts a few days. Some people, it lasts a few months. For some people, it does nothing at all. But that's what these injections are. You may read about them. You may see these advertisements, and I caution you when you see these. Even in our local ads, I've seen some physicians who put out things like this. New treatments, new non-operative treatments for knee pain, the Osteoarthritis Centers of America. It sounds very official, but what it is they're basically marketing physical therapy and these viscosupplementation injections. So it's not actually something new. It's not something innovative. A lot of these ads are simply ways to try to get patients in their door, but they're offering basically therapy and injections, something we've had for a long, long time. In terms of viscosupplementation, there have been large studies, and the results are equivocal at best. Basically, what these studies have shown is that really the viscosupplementation injections are really no better than someone who's taking NSAIDs or ibuprofen. So essentially, if you can take Advil or Aleve, you're probably getting the same effect you're going to get from one of those injections. In addition, in this study of 89 trials and over 12,000 patients, they basically found that the injections had some increase of adverse effects or side effects and really didn't have much great benefit in treating people with knee pain. But that's the literature out there. Again, it's somewhat controversial in how well it works. But there's no harm in trying. For example, if someone's going on a trip or trying to delay surgery or something like that. But it's not a long-term solution. In terms of surgical treatment options, there are essentially 4. And this algorithm comes from our Orthopedic Academy. The first one's arthroscopy. And arthroscopy we already talked about is using those small pencil-sized instruments to look inside the knee. And again, here's a diagram of that occurring, and here are the pictures that you can get. Knee arthroscopy is really best for treating meniscal tears. Some of you have been asking about meniscal tears. That's this. So rather than being smooth, C-shaped piece of cartilage, there's a tear here or a rent. Or here, you can see there's a probe coming in which is pulling on that tear. And so that causes pain. And so you can treat that with arthroscopy. It's a same-day procedure. It takes 20 minutes. People go home the same day. That's what arthroscopy is used for most commonly. It doesn't work as well for a knee like this. If cartilage is missing, arthroscopy can't put that cartilage back. Arthroscopy really only takes away. And as someone gets more and more arthritis, the problem is that they don't have enough to begin with. So arthroscopy isn't great the more arthritis that's in the knee. And in about 15% of patients, their arthritis may actually progress. And so we see patients who've had arthroscopy and now they need knee replacement. That does occur. Osteotomy, it's not as common. It's very infrequent nowadays actually, but it's literally termed for cutting bone. So when someone's out of alignment like this leg and they're developing arthritis, or when someone's bow-legged like someone asked a question earlier, the idea of osteotomy is to cut the bone in a controlled fracture and re-heal the bone in a better alignment. You can imagine there's a lot of downsides to that. It's very painful. It's a long recovery. There's risks of that bone not healing. So it's really more of a historical procedure, usually used in the young laborers, people who weren't ready for joint replacement. But because joint replacements are lasting longer and doing better, it's really starting to remove this procedure. But this is what it is. Maybe you've heard of it. The next 2 procedures, first I'll talk about knee replacement. So very simply, what is knee replacement? It's a little bit of a misnomer. It's not cutting out the whole knee and replacing everything. It's really a resurfacing of the knee. It's where a metal implant goes on the end of the thigh bone, and you can see how it's curved just like the natural femur is. And then plastic is inserted into metal, which goes on top of the shin bone. So basically, the areas where bone's rubbing on bone is resurfaced with artificial implants, metal on plastic. All the ligaments, muscles, tendons, everything around the knee stay their own, but the articulating surface where the bone meets bone is resurfaced. So if we go back to that x-ray, and here's a bowed leg because it's bone on the inside, not on the outside, and it's curved, this is what the implant looks like when it's inserted. So this is what a knee replacement implant looks like. So just to give you an idea, so you can see it and feel it and have a better understanding. This is a metal implant. This goes on the end of the thigh bone. This then will roll on the platform, which is plastic as the bearing, which is fixed to this metal implant on the bottom. So just like that x-ray, from the front, it looks like this, from the side like this, so that it can roll like so. But again, all the muscles, tendons, and ligaments around the knee remain that person's, okay? Knee implants are made out of cobalt, chrome, and titanium, and the plastic is a highly cross-linked polyethylene. Very, very, very durable. Knee replacement works great. Some of you may have a knee replacement, know someone who has it. They work very well. It's about a 3-month recovery is what we estimate. I'll talk about that more. But after knee replacement, people can walk, bike, swim, pain-free. A lot of people ask me, how long can they last? We expect lower than 1% failure per year, meaning at 20 years, we expect at least 80% still functioning. So it's getting better and better. And over 700,000 of these are done every year in the United States. So it's very, very common, okay? And we'll talk more about knee replacement shortly, but I wanted to at least give you the concept of what a knee replacement is, because before knee replacement, there's actually partial knee replacement. And this is something many of you may have not heard of and many people don't know about. Many surgeons don't perform this surgery because it's technically more difficult. Yet this is a wonderful procedure in people who have isolated arthritis to one part of their knee. So someone who has their arthritis picked up sooner. Rather than needing a full knee replacement, they may only need a partial knee replacement. And the concept's the same. It's metal, plastic on metal. So instead, if the knee doesn't look like this person has arthritis throughout their knee. They obviously need a full knee replacement like you're passing around. But this person just has arthritis in one part of the knee. So the question is do they really need the full knee replacement? Or could they just have part? Metal, plastic, metal, but obviously much less. The benefits of a partial knee replacement is that it's less invasive, the bone's conserved, there's less blood loss, every ligament is preserved, and I'll touch on that in a little bit, better range of motion, faster recovery. And so this is what it looks like, and this is what it looks like on x-ray. You can see instead of going all the way across, like on those other x-rays, it just resurfaces the worn part. It can be durable up to 15 years. Where I trained in Chicago, they have some of the longest research and studies on partial knee replacements because they do a high volume, and over 90% are functioning well at 15 years. But it has to be in the right patient. It has to be done by a surgeon who does them. And you just have to know a lot of surgeons don't do these. So someone who may be a candidate for this may walk into a doctor's office, and if that doctor doesn't do this procedure, they'll say, you need a full knee replacement, and that's it. When in actuality, they may be a candidate for something like a partial replacement. So something to know. And this is another model which you can use to compare. So unlike what you're passing along now, you can see that this is also metal on plastic, and as that knee moves, it's going to resurface where it was bone on bone, but you can see it stops. It just stops in the worn area, much smaller. So there are many benefits to this. I particularly like doing these procedures, but again, it's very important on selecting the right patient. If you look at the literature actually shows that partials or UKAs can have superior results to total knees. They can have better motion. Patients who have a partial knee on one side and a total knee on the other often prefer their partial, and they can have improved results. Now, I'm not saying there's anything wrong with a total knee. They work great, but these can even work even better. So it's a nice option to be aware of. This is that x-ray of a total knee, right? And you can see how it goes all the way across the knee. Again, this works great, and you can imagine is very fitting for a knee that has arthritis diffusely. But remember those cruciate ligaments we talked about? Those are no longer there with a total knee. With a partial knee, they remain. So that's the big difference. With a partial knee, you get to keep every single ligament in your knee, and that's why it moves better, has better function, has better feel. So that's why I prefer this, because this is obviously ideal if we can do it. Let's say this fails in 10 or 15 or 20 years. This can easily be converted to this so that that patient's getting their total knee for the first time 10, 15, 20 years later. So it's a great thing to know about. Again, you have to ask and see a surgeon who does them. Otherwise, you may not even know that you're a candidate. Okay. There are other partial knee replacements. So not only can you replace just the inside or just the outside, you can also replace just the kneecap. This is less common, but some people get kneecap-only arthritis, and rather than, again, replacing the whole knee, which works fine, again, I don't want the message for it to be that full knee replacement don't work well. They do, and you can treat this very well with a full knee replacement. But in someone who's appropriate, that may be overkill. They may be able to get away with just a kneecap-only replacement. So I also like doing these procedures because it has all the same benefits we mentioned before of less surgery. In this model, you can see when the knee bends and the kneecap glides in the femur, if that's arthritic and painful, you can replace just that. Put a metal groove, plastic on the back of the kneecap, which is exactly the same as in a total knee. Both a total knee and a partial kneecap replacement, put a plastic button on the back. But here, when it moves, it's metal on plastic just in the kneecap, thereby saving the inner knee, outer knee, meniscus, cruciate ligaments, everything. So again, another benefit to partial knee replacement, but only in the right patient. You can pass this around and again. Okay, so I know there will be questions about this, but before we get to that, let me just show you a little bit of an animation of what partial knee replacement is. So this is that knee model. It's moving. Their arthritis is only on one part. Every time this person bends or bears weight, it's painful on that side. But rather than replacing the entire knee, you can put metal, plastic, and metal just on that affected area. So you can see in this animation here, that's what they do. The knee functions the same. They can have a great outcome. So this is a patient of mine, which was a young patient. So I was hesitant to do something like a full knee replacement. I've known her for many years, and 2 years before surgery, she had knee pain, but her knee looked like this. Still pretty good space. She had many knee surgeries prior to meeting me. 1 year prior to surgery, still decent space, but right before surgery, you can see where it all disappeared. She was now bone on bone, but it was only on one part of her knee. She was young, so we replaced just the inner aspect of her knee, partial knee replacement, saving the rest of her knee. This is from the side view. You can see it's curved just like the native knee, but her kneecap stays her own, cruciate ligaments stay her own, the outside. This is her less than 2 weeks after surgery, moving her knee very well. Okay, great range of motion, no swelling, no pain. So it can be a very wonderful procedure. This is her walking at that time. It's hard to tell what knee had surgery. So again, it can be a great procedure in the right patient. And this saved her from needing a total knee replacement. So that's partial knee replacement. Now more about total knee replacement. We talked about it a little bit, but let's talk about less invasive knee replacement. And that's what we do here. Why do we do that? Because people want to recover faster. People want to be able to do more activities sooner. And so by using special surgical techniques, people can have those benefits of having a faster recovery from surgery. So by having a smaller incision, having reduced trauma to the underlying soft tissues, people can move better, walk faster, get back to their activities sooner. And that's involved us modifying our surgical technique, knowing where to place the incision, knowing how to address the soft tissues, modifying our instruments. But the idea is that we're trying to put in a knee the same. It's the same implant you're passing around, whether you have standard replacement or less invasive surgery. But rather than you doing a surgical approach like this, where everything's exposed, or a long incision like this, we try to do it through a much smaller incision. So you can imagine that that person has the ability to recover much faster. Why doesn't everyone do it? Because it's technically very difficult. You want to go to someone who does many of them and is a specialist, because it's hard to do. Not everyone can do it well, but people can recover quickly. This is our typical exposure in the operating room. It's a limited exposure. You can imagine trying to put those implants you're passing around through an incision like this is difficult, but we do it because one, we can do it safely, and two, because people can recover faster. Now this is going to be, for those of you who don't want to watch, is a little bit of a video from the operating room. There will be no blood. You don't have to worry about that, but this is just a little idea of what we do in the operating room. So this is me marking the landmark of where I'm going to do the incision, and everything's blue because it's sterile. The leg's a little orange because, again, that antibiotic sticky barrier. But basically, we dissect down to the knee tissue. There's no blood because there's a tourniquet. Patient has no pain because they have an epidural anesthesia. 15% of my patients will actually watch their own surgery. So they're watching this on a video talking to me while I'm doing it, believe it or not. But this is their kneecap, and their kneecap is lacking cartilage. And so I measure it because I want to restore it to the same width when I'm done. But basically what I do is I take tools like from Home Depot. Orthopedists are just carpenters. We use saws, drills, and hammers. And what we're doing is we are resurfacing the back of that kneecap, and so that we can prepare it with a plastic button so it doesn't hurt. This drill goes into the bone to allow for alignment, okay? If you don't like this, just keep your eyes closed. It's almost over. But all these jigs basically allow us to figure out how to put in the implants in just the right position. So all these jigs allow us to use the patient's alignment to figure out how to put these things in. Again, here comes the saw. We have the hammer and the drill. Here's the saw. But we trim just a few millimeters of bone. The idea is to take away just enough bone so that when we put the implant in, it restores the same shape and anatomy of the bone of what it was beforehand. So we only take out what we plan to remove. We have all these jigs and all these other things to make sure all the cuts are precise. But you can see there's not a lot of room. Right? It's not like that picture where you can see the entire knee. We're working through a small window. This surgery only takes about an hour, a little bit less. And so then after we finished all these cuts and made preparations, the thigh bone's now prepared. I now prepare the shin bone. And again, just take a few millimeters to make a level surface for the implant that you passed around. And what you're going to see here is you can see the cartilage is missing right here. All of this is absence of cartilage. It's all worn here. It's just down to raw bone. So that's why we're doing this procedure. And so I have trial implants. I put them in. I prepare. I make sure everything's fitting appropriate. The knee works well, is aligned well. And we test it before we cement it in. So standard of care for knee replacements to use cement, so it's in securely. These are the trial implants going in. So again, I can test to make sure that I like exactly how everything is looking. And when I'm satisfied after testing the range of motion and the stability of the knee, then I can cement it in. So you can see I can test that knee to see how it feels with range of motion and stability. And once I'm happy with that, then we can glue in the actual component. The glue we use is just like what you have at the dentist. It solidifies very quickly. It's hard before we leave the operating room. I use a cement that has a little bit of antibiotic in it, The idea is that that leaches out into the joint to help prevent infection, we hope. So we do have that capability. It's green so that we can see it and clean it out well, but this is that implant that you're passing around. So we're trying to maneuver this through that small incision and to impact it into place and remove the excess cement. I guess you wouldn't watch your own, you wouldn't be one of those people who would watch their own surgery, I guess. But the people who watch it do say that they have a better understanding of what's happening and they have a better understanding of the recovery. So there are some, again, it's not for everybody, but some people do. So these are the shiny new components going in, which is going to allow this person to walk the next morning. Okay? So let me show you a little video to give you the idea of a typical patient. This was an interesting patient. He's actually a therapist. He came to me. He did not tell me he was going to take pictures before surgery. So he took these and gave them to me later. See how his leg's bowed? Someone asked about a bowed leg. See how it's curved? And see from the side how it won't straighten all the way? This was his leg before surgery. Again, he took these at home before surgery, didn't tell me, and gave them to me afterwards. We did his knee replacement to improve his range of motion and flexibility, take away his pain. He took the pictures. Look how straight that knee is compared to before. The alignment is now corrected. His motion is better. See how straight it was compared to before? He can move that leg appropriately. And so this is him walking, leaving the hospital 2 days after surgery with a cane. So this kind of recovery is dramatically faster than the kinds of things that happened when I was in training. People used to be in the hospital for 4 or 5 days, go on a rehab for weeks, be on a walker for 6 weeks, cane at 2 days. Okay, so that's the benefit of less invasive surgery. We are not going to do that and jeopardize long-term results. Obviously, what we all want is a good long-term outcome, but if we can give the same long-term, good, reliable outcome and provide a faster recovery, we think that's in the benefit of the patient. And so again, this is that patient walking home with one of our therapists. This is our old Center for Joint Replacement building, but this is him walking home. So pain's well controlled. People have a much faster recovery. And I just want to show you what he looks like at his first visit after surgery. This is him on his first visit, 2 weeks after surgery, right? Walking pretty well. I can't tell what knee was operated on. So it's a wonderful thing. Advances have really occurred, and it's great that we can get people feeling better faster, okay? Some of the things you might hear about or read about in the media, are men and women different? Well, this company, Zimmer, we happen to use, did come out with a gender-specific knee. It's not a pink knee or something like that, but it's actually a knee that is made differently because women's anatomy is a little different than a man's. The women's anatomy, the femur is a little narrower, there's a little less bone out on the front aspect of the femur, and the patella tracks at a slightly different angle. So they actually came out with a whole different set of implants specifically for the woman to match their anatomy better. And so we do use that company. We use a lot of the female implants. A small percentage of women do not get the female implant just because it doesn't fit them as well. And some men actually get the female implant because it does fit them a little better. It doesn't really matter if you call it male or female. What's really most important is it gave us more implants to pick from to individualize for that patient. And that's what's nice. And other companies have now taken that on, as Zimmer has as well, so that we can more customize or individualize our knee replacements. And it's, again, trying to get away from having one implant for the average person and really trying to treat everyone a little bit differently. The other thing you might hear about is computer navigation. If you hear about computers, you think it must be better, right? What in our life is not being affected by computers? Everything's becoming automated. But as you know from your experiences, not everything with the computer is necessarily better. I mean, some of us probably yearn for times when everything wasn't computerized. The idea of this is using a computer in surgery to help the surgeon put in the implants. What that means is that not only do you now bring in a computer into the operating room, but you have to have some sort of marker in the leg to let that computer know what's happening. So you have to drill holes in to attach these probes for the computer to recognize. The problem is before we weren't drilling holes in like this, we weren't using probes, and that there have been some case reports where people actually fractured through these holes that we used to not use. So in trying to introduce a new and better technology, we've also introduced a complication that never used to exist. In addition, with marketing, people will say it's more accurate, it doesn't slow things down, it's better for the patient, and it can turn a good surgeon into a great surgeon. The problem is that all those things are unfortunately myths. The studies show that computer navigation does not, in fact, help long-term results, and in some cases, it can even be worse. So unfortunately, the technology is not there. And I'll talk a little bit more about this later. It's similar to another analogy that one of my mentors, a different mentor in Boston, who told me using navigation in the operating room is like using GPS in your car. Do any of you use GPS in your car to go from work to home? No, because you do it every single day. Knee surgery should be the same. You shouldn't be depending on something to tell you. You should have been there before. And of course, you don't want to be in this situation where the GPS is telling you, sorry, return to the main road. It's too late, right? We don't want that in someone's surgery. Other things that are out there are things like the rotating knee, the golfer's knee, saying that it has more motion. What this was one specific company who were having problems with wear on the backside of their plastic. Usually the plastic's locked into the metal, like on what you passed around. Their plastic was moving a little bit, and so in order to try to address that, they said, well, why don't we make it move on purpose? So what they did was they made a plastic that would actually spin a little bit on the plastic. It's a good idea, right? Eliminate one problem, but then it introduced a problem we had never seen before, which is that plastic could actually dislocate. So this plastic has spun 90 degrees. So now this patient needs a revision surgery. So again, the theme is be cautious with new technology because it can introduce a problem we have never seen before. This is a very hot topic right now. A lot of patient direct marketing of patient-specific instruments. It needs to be clarified that what this involves is using a CT or MRI scan, so more expense, and in the case of CT scan, a lot of radiation for a patient, which they typically didn't get before, to send to a computer to make a jig. And the jigs look like this. They're plastic, they go on the bone specific to that patient. These jigs are made for the individual patient, but they're there to put 2 pins. Once you put those pins, you put the same standard instruments that you used before. So it's not a personalized knee, it's not a patient-specific implant, it's still an off-the-shelf implant, but there are patients out there who are misled and say, oh, I have a personalized knee. They don't actually have a personalized knee. They had a personalized jig, and its only purpose was to place 2 pins to then do the rest of the surgery. Okay, so it's a lot of expense for maybe not much gain. And the literature in these studies have shown that they actually don't improve things. So again, a new technology which sounds great, but if it doesn't improve long-term outcomes, do we really need to do it? Another hot topic, and you'll see a lot of advertising, is the Mako machine. The Mako is this $1 million robot that physicians and hospitals will use in order to promote their programs and try to get patients in the door. What it does is it takes images prior to surgery, goes into the computer, and then this robot helps guide the surgeon on where to take the bone away. It is an interesting technology in that arm, it's blocked so you can't go too far or other things. The problem is that this computer, right, is only as good as the information that goes into it. And so the risk is what if that computer malfunctions? What if something is different in surgery and the computer isn't aware of it? Does the surgeon know how to address that? Or will it become a problem that can't be solved? And just like any other computer, you know, to err is human, but to really foul things up requires a computer, right? Same thing here. Same thing here. The Mako, if you look on the internet, there have been adverse events where the machines malfunction mid-case. There's a lot of risk, and there's no studies to show it's any better than our standard techniques. So be cautious again of advertisements of these technologies until something's proven. These are just more summaries of recent technological so-called advances that failed. Okay, so you have to be careful. So in summary, with new technologies, we're always striving to improve, yes, but remember that the standard of care has excellent results. The only way for new technology to be better is it has to have equally good long-term results as our standard of care. Be cautious with advertisements, be careful with what you read, and really talk it over well with your doctor, okay? Along those same lines, and I will answer questions at the end again, there are various perioperative advancements. So a lot of exciting things that I've been introducing in my practice as others have to try to help the other aspects of care around surgery. The first is pain control. Traditionally, you know, it's narcotics, things like morphine, Vicodin, Percocet. Those have side effects, constipation, nausea, drowsiness. It's not terribly fun for the patient. And so if we can avoid those things while still providing good pain control, that would be ideal. So less invasive surgery certainly helps. It's less painful. But it's also a matter of having a good understanding of where pain occurs. It occurs at the local level, at the surgery site. It goes through the nerves to the spine, and then it also goes to the brain. And so rather than just dosing someone heavily with narcotics, our goal is to address all of these areas. So by using local anesthetics or anti-inflammatories mixed with narcotics as necessary, or regional anesthesia, or other modalities, we can address pain in multiple levels to allow that fast recovery that you saw before. But it takes an integrated approach and a very dedicated program. So just some of the things that I use, Tylenol, as simple as it is, there is IV form Tylenol. And that IV Tylenol can provide pain relief even faster. It can go into the bloodstream and brain quicker, and so around surgery it can give great relief. So the same medicine, just delivered in a different way. Or Celebrex you've heard about, or other anti-inflammatories, other ways to help with pain relief through a different mechanism, remember. That's a different mechanism of pain relief. And there's also an IV form of that, which I like to use. A great pain reliever with really few side effects. I'm also using something called Lyrica. Some of you maybe on Lyrica have heard about it. It's a nerve type medicine, but some of the studies have shown that in low doses, it can help reduce the chances of chronic pain after surgery or even pain medicine use around surgery. But it's important for surgeons to know about all of these advances. We can use various things to help with pain control. We typically use epidural anesthesia, so numbing medicine in the spine so that they're numb waist down, have no pain. People will use things like nerve blocks or other things. All of these things are options. Again, we want to do what's best for our patients to minimize pain. This is one of the newer medications. It's called Exparel. It's like Marcaine or Novocaine, like what you get at the dentist, but rather than wearing off in hours, we inject this around the surgical site and it can last for 3 days. This is newer. This is something that I started using maybe half a year ago, and I'm working with this company because it seems to have such a great result. People are having less pain, less need for narcotics, less side effects because their pain is well relieved with this. Rather than causing pain relief like this and going down, it comes up and slowly goes away over 72 hours. So again, a very interesting medication, something we're testing, want to make sure it works well. There was an article in the paper recently about it. It's something we're using that can work very well. I combine this with other medicines I've used. Tranexamic acid it's a clot stabilizer. What it does is it basically helps prevent blood loss with surgery. You have to use it in certain people. You have to be cautious of people that may be at risk. But with this, I have found that blood loss after even hip or knee replacement is minimal. Our transfusion rate before using this was extremely low. It's even lower with this, is what my preliminary data is showing. So again, new advances that are helping. This is a cautery type device, which helps stop bleeding during surgery. So again, while we're looking at it, we can stop bleeding by providing some local energy to coagulate vessels. This is another product I've tried, which is something that has thrombin or something that helps clot. You apply it locally, and it stops bleeding. And I have a study that shows it reduced transfusion rate, reduced blood loss after surgery. Obviously, all these things can help how someone feels. Less blood loss means they have more energy, means they don't have draining wounds, means they don't have pain from hematomas in the joint. Obviously, many, many benefits. Another advancement that I've used recently is this suture. It's a barbed suture. So unlike traditional suture, which you're aware of, where you put the suture in and you tie the ends, this actually has barbs in it. So it engages the tissue with every throw, so you don't have to tie knots. It actually engages along the entire length of the incision. So the suture looks like this. It has little barbs or nicks in it, and so that catches in the tissue. So rather than tying a big knot at either end, it's securing along every throw. And so what's nice about that is, one, there's no suture irritation because there's less suture. It's a faster closure because I don't have to tie knots. The way it's made is the barbs go in opposite directions, so I can close one way and someone else can close the other, so it's faster. But it can let us approximate something like this. This is a knee incision, no staples. It's watertight, and the forces are distributed evenly throughout the wound. So it's been a wonderful, wonderful, small advancement, but combined with other things makes a great change. This is with a hip surgery. Again, it closes things with knotless suture. The last thing I'm going to talk about is this dressing. Rather than changing dressings with standard tape, which causes blisters and hurts, and you have to ask a caretaker or loved one to do it every single day, right, which may not be their forte, this dressing here can stay on for a week. It's sterile underneath. It has an antibiotic material below it. So I brought this to the hospital maybe a couple years ago now. It's a little bit more expensive, but the studies show that this actually can have some benefit in reducing infection because no one's changing it. So the convenience is that it will absorb any moisture that comes through the incision. It has an antibiotic layer. It's watertight. You can shower with it right away, but it stays on for 7 days. So rather than this kind of thing where we had draining or you had tape or other things that had to be changed, this kind of dressing goes on and stays on for a week. Again, another small change, but the combination of these small changes allows faster recovery. And what does that mean? It means that we are on the verge of beginning outpatient joint replacement. I'm currently in talks with our surgery center to figure out, can we do joint replacement and have people go home the same day? Because our pain is that well controlled, people recover that fast. So that's where we are going and will be coming most likely very soon. Lastly, before we answer questions, I want to tell you a little bit about our Institute for Joint Restoration. Things that we have which are unique to our program are our therapists and nurses. We have a preoperative class. So anyone having surgery here goes to a class taught by our therapists and nurses so they know everything they need to know about before, during, and after surgery. Their questions are answered. They hear other patients' questions answered. We also provide knee binders or hip binders. They're thick, full of the same information. So again, as a reference, people can be aware of what is happening before and after surgery. The reason we can do this is because we have a huge personnel. It takes a team to do this. It takes the surgeons, but it takes anesthesiologists, OR nurses, OR techs, therapists, floor nurses to all make this possible. And we're very fortunate the hospital has provided us with that, and we can provide that kind of service to our patients. This is what our unit looks like upstairs. We're just approaching our 2nd birthday. Our office is on the top floor, and our unit, much wider halls, bigger therapy places, but all private rooms. So there's no roommate, all private bathrooms and showers. There's no one else on that unit who isn't having an elective joint replacement. There are no sick people in that building. The sick people are in the hospital. The healthy elective joint replacement patients are in this building quarantined. That makes a huge benefit, obviously reducing infection and other things. So care is only about joint replacement. With our program, we're able to write articles, publish them in peer-reviewed journals, present data yearly at national meetings. This is a hip study that I presented at a national meeting, and these are an example on knee replacement outcomes that we presented in San Francisco 2012. I presented this at our AAOS, or national meeting. We have numerous information that we are sharing with the rest of the country because of our large database, our large volume, and the protocols that we do here. So we're able to do this year in, year out. This is Fremont. This is where we are. We're a small community hospital, as you know, but the joint program extends well beyond that. People drive past their local hospitals to come here because they want to have their care here. And we feel very privileged to do that, but there's an expectation that we have to meet with that. We have had many accolades. This is satisfaction. This is the #1 orthopedic facility number of years in a row based on patient satisfaction with our orthopedic program. Health grades, you can look on the computer. They rank 5,000 hospitals across the country, whether they like it or not. 5 stars is their highest rating. They give us 5 stars in both hip and knee replacement since 2002. In 2012, we were actually the #1 joint replacement center in all of California. So right here in your backyard, the #1 joint replacement program in California. So we're very proud of that, but again, with that comes great responsibility. Consumer Report just came out with this in September 2013, looking at their safest places for hip and knee surgery. Washington Hospital had their best. Stanford and UCSF, you can see, is 2 ratings below. Looking at the highest rated for knee surgery, this is the highest rated, this handful of places, Washington Hospital. Highest for hip surgery, handful of places, but we're one of just a couple that are the highest in both. So again, we are very fortunate to have the program, the facility, the personnel to provide the level of care that we want to. This is our website. There's more information on our website. This is our phone number to make an appointment. If you want to make an appointment, if you mention that you came to this seminar, I've asked my staff to hold some spots so that people can come in sooner. So if you mention this seminar when you call, we'll try to get you in sooner. Thank you all very much again for your attention. Thank you.